And we're now on the down low, which means we're going back, 5 more weeks after this. We have our exam that we've done. Remember, there's a discussion question this week, and then there is a case study, the ALL, which is open. If y'all didn't get your NCLEX question or case studies, you have 1 more week that they're open. A couple students, not many, but some didn't get them done. Remember, you still can turn them in with a 10% deduction, okay? Also, remember that clinical pediatric assessment, it's the assignment, it's 3 parts. Make sure that you clear your diagnosis through me. I mean, I've actually had some interesting diagnoses I've never heard of, and I love those. And actually it was her daughter. So the latest one that I have seen. So that's pretty neat that I can read about something I don't know about, and it was something that was close to the student. And I love it when you pick things like that. So again, just let me know. And the sooner you get that into me, I can tell you what's wrong or what could be tweaked so you can get your full credit. I have no problem giving hundreds out on this as long as it's done to a certain standard, okay? And if it's not, I'll let you know. All you have to do is make changes, okay?
Thank you.
No, you're absolutely welcome.
Can I speak with you after class?
And who is this?
Jamie.
Jamie. Did I hear Jamie?
Jamie McGuire.
Okay, no problem at all, okay?
Okay, perfect. Thank you.
All right, we're gonna be doing our
Why are
code.
you staring at me? Every time I'm on class.
So we're gonna be doing our Kahoots. Again, I'm gonna be talking over it, trying to help y'all with it. Remember, there is a PowerPoint. You go back and look at it. And these are those concepts within here that you need to understand. So at any point, you're not getting it, stop me, because we're going to go into diabetes type 1 here, all through a Kahoots, and you're going to understand it's not as complicated as everyone makes it. Yes, it is a big disease, and it's metabolic, it's respiratory, yeah, all that good stuff, but I'm going to make it sound the best I can for you. Is everybody muted? I thought I heard somebody walking. All right, let's just get going so we get it done. And you should be right there at 5 o'clock today.
I didn't get the code, but I'll look at it.
Okay. Growth hormone is administered via which route? Your code is 410696. Now, growth hormone is a hormone secreted by the pituitary gland. And growth hormone shows you how tall you are, and that's why we do all these heights and weights. Now, growth hormone is actually a subcutaneous injection, usually given daily or weekly or bi-weekly, whatever the physician wants it to be. And what we do is, those are for those children who are really tiny, really small, and they're not, the same height as other children, and the parents are a decent height. So we'll give it up to the point where they stop growing more than an inch a year. So if they're not growing an inch a year, we will stop it, and that will be the final height for that child. So sub-Q injection for growth hormones. Highest priority for a patient diagnosed with syndrome of inappropriate antidiuretic hormone. So inappropriate means something's going wrong, of anti-urinating. So this means this child is not putting out urine due to a hormone secreted by the pituitary gland. It's SIAD. H is the other initials, but it is inappropriate, too much urine going out, too much stop the urine hormone, basically and very simply. So again, what are we going to watch? Absolutely intake and output, and your retaining fluid. You're going to listen to lungs and look for, swelling and the edema, etc. And weights, always daily weights. Intake, output, daily weights. They go hand in hand. With the elderly patient, it would be if they can, and of course, most children get on a scale. Which of the following are signs and symptoms of an inappropriate anti-diuretic hormone? Too much of against urinating hormone. That makes sense that way, doesn't it? So we're not going to have urine output because it's against that diuresis. So you're retaining fluid. So it's a decrease in urinary output.
That shouldn't be an increase in urinary output.
No, it's an inappropriate anti-diuretic. Means against diuresis, against urinating. It's too much hormone secreted to stop urinating. So you're not urinating. It's decreased urinary output.
Oh,
Okay, you're going to be swelling.
so ADH, it
That's
holds it,
completely
but
different.
the other one, it's
Yes,
like it's
SIADH is stopping urine, and we're going to get to the other one, which is urinating, which is diabetes insipidus. Okay. What is important to cover when teaching the family about proliprophysil? I call it PTU. It's a medication that's given for hyperthyroidism. And there's a side effect that these patients taking it are parents of children, and children need to know this is a side effect. This causes leukopenia, which means what? You're immunosuppressed, susceptible to infections. So you're at risk for fever, sore throat. So they need to be really careful, hand washing and protecting themselves, especially today. An initial sign of diabetes insipidus. Well, diabetes insipidus is, again, the pituitary gland secreting the hormone, and it's absolutely opposite of SIADH. And what happens is you're thirsty, and you urinate. So it's polydipsia, polyuria. So what are you at risk for? Well, you're losing all your electrolytes with all this urinating. That's one of the big things. And then, of course, all the urinary output going out. How do we treat diabetes insipidus? We treat it with vasopressin, right? And it will stop that urinary output. That's when we know that medication is working. The urinary output decreases in diabetes insipidus. A multi-select. What are the clinical manifestations of juvenile hypothyroidism? It's the same as adults. Hypothyroidism, what do you see? In fact, this is one of the things that at birth, if you are not moving your bowels, not having a stool within 3 days, they're going to be checking you for thyroid problem. So constipation is absolutely up there. But that dry and the skin and the hair is thinning, decreased growth, cold intolerance, all the things you see with adult hypothyroidism, you're going to be seeing with children. A child has simple febrile seizure. What education would you provide the parents? Now, febrile seizures are the most common of all seizures. Usually febrile seizures are due to a sudden rate of rise or increase in temperature from 0 to 101 in 20 minutes. And the brain says, whoa, wait a second, what happened? There's fever, there's fire in my head, and it synapses or sparks, and a seizure ensues. So whenever we have any patient, whether child, adult, and we know that they're having seizures, what is our number one priority? And that is safety. Safety is always priority. We can't do much of anything else, right? but we can protect them. We can have them turn to their side in case they vomit so they don't aspirate. But safety is always a big thing. And on your NCLEX, they love safety. What type of seizure is when the body is jerking, foaming at the mouth, and the child is rendered unconscious? Well, this isn't a febrile seizure. This is a child who has a seizure problem. Something's going on. And it's called a tonic-clonic. So that's like full body if you look at it, okay? Tonic-clonic seizures. After a fall, what assessment would be considered a neurological emergency? And I've seen children fall out of second-story balconies, off of roofs, come in, and it's the first thing that we're going to be doing is checking this child for neurological status. When you see this, you're in trouble and you need a neurosurgeon like now. And that's that fixed dilated pupil. What is telling you there's pressure on that brain? There's probably bleeding going on that brain, and we need to get that swelling to go away because it's pushing on vital brain parts in there, okay? And it goes, you can see it with the eye. Yes, they'll be lethargic. Yes, they'll have amnesia. They're going to be, you know, they don't know where they are, very confused. They're may or may not vomit. Children tend to vomit and adults don't in head injuries. So you can't tell that with adults, but children, you have a headache, profuse vomiting. We know that there's something going on, but the emergency is that pupil. With a patient with a head injury, the signs of increased intracranial pressure include what? Sort of went on something of that. So it's that change in level of consciousness. Now, pupil size equal? No, it's bilateral pupil size increase. It's not saying that there's an unequal something there. So it depends on the light in the room. Is it dark? Is it bright? That affects pupil size. But a change in level of consciousness, you know, we describe it amnesia in pediatrics. This will be the child, and this is where I see head injuries the most. They're usually sports injuries. Slid into third base, the head hit the knee, and they come in because they were rendered unconscious at the scene. They come in and they're talking, they walk in, and then all of a sudden keep asking, so is dad coming? And mom keeps saying, yeah, I told you 20 minutes ago, he's on his way. And then 2 minutes later, is dad coming? Or did I win the game? Or was I safe? And repeatedly over and over again. And that is considered that change in level of consciousness, like that amnesia. What notable sign may indicate increased intracranial pressure in an infant? Now, an infant can't tell you they have a headache. They can't tell you they're nauseous. I mean, they can show vomiting. I mean, they have pupils, yes, but there's one thing that you will know every time that you know something's going on neurologically with an infant. And it's not a bulging fontanelle when crying. That is normal, okay? A bulging fontanelle at rest, that would tell me a little bit more, but this high-pitched crying, it's not like a normal infant's cry. It's like when you hear it, it's like nails on a chalkboard. That's how different it is. You know, infants have the way of telling us what's going on, just like with increased respiratory problems and not doing well, not breathing good, they start grunting and nasal flaring. Well, in neuro problems, intracranial pressure, it's that high-pitched cry that they show us. They're very subtle in how they talk to us. All of the following increase intracranial pressure except what? You know, as nurses, we need to care for our patients, and we're going to have patients with increased intracranial pressure. We will. So many times we don't want to increase the pressure, so we need to know what increases it. And tachycardia has nothing to do with pressure. Turning the patient, yes, it will, because you're touching them, turning them. Coughing absolutely increases pressure. And if we have to suction through an endotracheal tube or orally, that again is going to increase pressure. But the heart rate has nothing to do with intracranial pressure. Which of the following signs and symptoms are more common in children than adults following a head injury? I've just briefly mentioned it. A little bump on the head looks like my grandson last weekend. He fell out of bed at 3 o'clock in the morning and went headfirst on a, tile floor, and he had one of those bumps. Now, what do you see in children more than adults? And that's the nausea, vomiting. Adults, even when they've been hit really hard in the head, they've got a massive headache, but you don't see them vomiting. Children, you bop them on the head and they're more tend to start vomiting quicker than adults do, if the adult does. What medication may be used for a child with cerebral edema due to a fall? Well, look at that. It's swelling in the brain. What do we use for swelling in the brain? Of these medicines, swelling in the brain, how are we going to get that swelling gone? And it's mannitol. Remember, diuretics, furosemide is peripheral edema or your lungs, yes. But for the brain to decrease swelling quickly, the mannitol, okay, is the drug of choice for cerebral edema. Okay? Reyes syndrome, what's that? So it is caused by aspirin. It's a metabolic disorder we don't know about until they take the aspirin, and it is in children. This is why we don't give any aspirin products to children unless they have Kawasaki disease. That's the only time we'll use aspirin with children. Febrile seizures usually occur in patients between what and what? Children in, teenagers in, adults then. My grandson at 18 months old, the first one had a febrile seizure. He only had one in his lifetime because the mother has a thermometer and antipyretic she carries with her constantly. But it's between 6 months and about 6 years they grow out of it. What do we tell a parent whose child just had a febrile seizure? Is my child have epilepsy? Well, the answer is no. We can't determine that on one seizure. Usually they grow out of them. Usually it is not epilepsy unless it occurs more and more frequently. Childhood hypopituitarism results in which condition? What sort of hormones does the pituitary gland secrete? And one of them is the growth syndrome, growth hormone. So if they don't have enough, hypo, less than, they could be small children, as in dwarfism. What do? Well, we can replace the growth hormone, right? And we can give subcutaneous injections as ordered to help get them bigger. How would you describe precocious puberty? And these are all hormones that I'm talking about. So precocious puberty is when you reach puberty early. It's boys and girls. You'll see young boys at age 6 with beards. You'll see young girls at age 6 with, breasts. And we can stop, puberty from occurring then, because being a 6-year-old with breasts or a beard, can you imagine the amount of teasing? But it can happen. So we do suppress it, and there are medicines that they can take for that. Congenital hypothyroidism. So born with low thyroid hormone. Well, we know usually, unless the parent has thyroid problems, it doesn't get checked. But if they're not having a stool in the first 3 days of life, they're going to be checking for a thyroid disease. So it does cause a lot of problems with cognition if we don't find it and replace that hormone. Female are more, and it could be also due to mom. So congenital hypothyroidism is usually found at birth because of no stools, or because mommy has she's with a thyroid problem. What acid-base alteration would you see in a diabetic child with Kussmaul respirations? Well, a diabetic child with Kussmaul is in diabetic ketoacidosis. So the body wants to correct that metabolic acidosis. So what do Kussmaul respirations do for that? We're going to do the opposite. So metabolic acidosis, so we want something respiratory, and we want it alkalotic. Remember, Kussmaul is these long pursed breaths, okay? So that causes an alkalotic state in the respiratory system, trying to correct the metabolic diabetic ketoacidosis. Okay, the body's trying to correct it by breathing longer and producing more bicarb. Now, I give you all these acid-base questions because I saw 4 of them on your HESI, and I want you to have that, practice as we go along through the course. What would a child with Cushing syndrome look like? Multi-select. Well, what is Cushing syndrome? Something to do with adrenal glands. Something to do with too much prednisone, steroids in the body. What do you look like? So you're going to have that big round face. You're going to be thick, stocky, big round belly. You're going to have hair growth. And you're going to have skinny arms and skinny legs usually. That goes along with it. Now, what do we do for Cushing syndrome? Well, if we're giving this child steroids, we're going to taper them off slowly. And all of this stuff will come back. The moon face will disappear. The hair growth will stop, and that big pendulous belly, hopefully we'll lose all that stuff. Seizures in children most often are the result of what? So seizures, which is febrile seizures, is not because of a temperature that they have, okay? I've had parents come in screaming, oh my God, my child's gonna have a seizure. They have 104 fever. And I'm like, well, your child already has a fever, so actually that's a good thing. Let's go get some Tylenol or Motrin, because of course they didn't get anything yet because we wanted to show you that fever. But it is from 0. You're at 98 and all of a sudden you go to 101, okay? It is that abrupt rise of temperature. Once you have a fever, you're actually safe. And the chances of life-threatening side effects like seizures actually goes down to almost nothing with a fever. An autoimmune disease of the thyroid gland. My daughter-in-law has this. Usually your, late school age, adolescent females are the ones who get this. And this is one of those things that, you know, your hormones are out of whack and you have to take replacements, but there is not a surgical intervention for this. This is only medical. This is only medication to replace those hormones that they don't have. Addison's disease. It's another adrenal gland problem. What do we know about adrenal gland? We have Cushing's, we have Addison's. So we know that the adrenal gland secretes cortisol and aldosterone. In Addison's disease, there's not enough, so it's decreased. In Cushing's disease, there's too much, and it's usually because we take steroids by mouth also. A multi-select. A ventriculoperitoneal shunt. Well, if we look at that, that is the ventricle in the brain. And there's a tube that goes from there, behind the ear, down the neck, into the peritoneum, and it drains fluids for that child who has too much water in the brain or hydrocephalus. We can tell by that big swollen fontanelle that there's too much fluid in there. So we use it for hydrocephalus. You will not touch that pump. The physicians, there's like this little round thing that you could push. We don't touch that at all. They can pump it. And our job as nurses is to measure the head circumference once a shift. And if it's a smaller child, I'm going to be measuring their abdomen too. See how much fluid is going in there. It has nothing to do with bleeding in the brain or epidural hemorrhage. It has nothing to do with that. It just means there's a block, the fluid can't get down, it's swelling into the brain. We need another method to get rid of it. We put in this shunt. A common sign of Graves' disease includes blank or a protrusion of the eyes. Graves' disease is hyperthyroidism. There's commercials on TVs right now. That lady that walks around with the glasses on, she takes the sunglasses, she takes one off, there's more there. And now there's these new drops and she doesn't need to cover her eyes anymore. And it's exophthalmos. X means external, ophthalmos, eyes. So it's bulging of the eyeballs, okay? Hyperthyroidism, bulging eyeballs. A multi-select. What are signs of hyperparathyroidism? Now, you think of parathyroid, it's not thyroid hormones. It doesn't regulate anything like that. When you talk about the parathyroid, you're talking about the regulation of calcium in the body. What does calcium do? Well, there are two minerals, calcium, magnesium. When you see them, think of muscle strength and spasms, okay? It can contract muscles, even to the point of being, you know, tetany, they spasms or tingling in the muscles. Calcium, magnesium, think muscles all the time. So what do you see when there's too much of this hyperparathyroidism? Well, you don't have calcium in there, so, or minimal. So that paresthesia, confusion, nausea, vomiting, all signs of it. A multi-select. Hypoparathyroid has the symptoms of tetanic muscle contractions and what? What did I tell you about calcium? What does it work on? So we can have too much calcium or not enough calcium. Hypoparathyroidism, not enough calcium. You don't have calciums, your muscles aren't going to work the way that they should. And you also go into those tetany, those spasms of your muscles. So again, parathyroid, think calcium, think muscle. What does the parathyroid hormone do? Now, after all that explanation, what does the parathyroid do? So it regulates the calcium in the blood, okay? Calcium, parathyroid, calcium. Growth hormones, pituitary gland. Which of the following might be a cause of an adrenal crisis or Addisonian crisis? Adrenal glands, what do they do? Something about cortisol and aldosterone. What would cause the adrenal glands to say, I don't like that? And it's when you go off steroids too quick and it causes this adrenal crisis. So that's why we never, ever just stop steroids. We need to taper them and take them off very slowly, especially if they're in that to the point of Cushing syndrome. I was there. A multi-select. Congenital hypoplasia parent teaching should include. Well, again, the pituitary gland talks about gender assignment on children, boys or girls. Now, I've seen babies born with a vagina and testicles. I have seen a penis and a vagina. So it's the body doesn't know if it's a boy or a girl, okay? Number one, there are no complete body parts. Therefore, this child will be infertile forever. Now, what they need to do is to do ultrasounds and see what sort of body parts are there. Also do hormone testing to see what are the hormones that this child has. Is it a boy or a girl? Can you imagine going home and they say, so did you have a boy or a girl? And you're like, I don't know. Because that's what happens with these children until we assign that gender to them. Again, because it has to do a lot, adrenal gland problems here, cortisol and aldosterone must be replaced. So that's congenital hypoplasia. What causes type 1 diabetes? Type 1 diabetes. Again, what causes it? And what happens, what the cause is the destruction of the beta cells by an autoimmune process. These children or adults are immunosuppressed. Their immune system is saying, okay, pancreas, let me come after you, you beta cells. You don't have beta cells, you're not going to produce insulin. And you're diabetic because you need help digesting the carbohydrates. What statement about a pheochromocytoma is correct? This is an adrenal gland tumor. Very difficult to find, but there are certain symptoms that we see with this. These tumors tend to secrete hormones that causes hypertension, causes tachycardia, causes tightness in the chest. You can also become very hot and febrile. Pheochromocytoma is a catecholamine producing tumor. Catecholamine, think everything fight or flight, up, 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 blood pressure, heart rate, okay? How do we, determine what these are? I mean, many of these children or adults start complaining, all of a sudden tight chest, all of a sudden their heart rates go up and they get these headaches because of what they're feeling and they can't find it. So when they go looking, they're gonna find this pheochromocytoma and they need to remove it. A multi-select. What action should the nurse implement in the care of a patient with a pheochromocytoma? So this patient's coming in for this removal. What is your plan of care? What should you be doing for this child? I mean, what are all the side effects of pheochromocytoma? Because they're going to surgery, they still have it now. And we're going to be monitoring for that heart rate and for that blood pressure. Okay, definitely we're going to be watching that. Has nothing to do with weight gain, has nothing to do with sugar. It's an adrenal problem. Catecholamine, sympathetic means heart rate up, blood pressure up. We're going to look for that, monitoring close vital signs. Another multi-select. Nursing care the unconscious child should include. So when we're talking about unconscious, we're thinking of a child who maybe has a neural problem. We're going to be doing neuro checks every 2 hours with vital signs. One of the biggest things with unconscious children is intake and output. We don't want extra fluid going into the brain causing any swelling. Pain control is not really our first control. It's also, the other stuff, but something, I wouldn't say it's wrong. I'm going to change that for next class. Symptoms of DKA, diabetic ketoacidosis. I've worked in the emergency room where we have type 1 diabetics that come in DKA. And what do I see? Well, you see this child come in. Usually they're more of the adolescent who don't work with their diabetes well. And they come in and they're pale, they're dry, they are lethargic, they're sitting in a wheelchair bent over, and they're just, you can smell this rotten fruit smell. Think of a peach, put it in a Tupperware container, leave it there for a month in the refrigerator, take it out and open it up, and the smell that you'll get, it's like a rotten peach. That is what you see in fruity breath. You'll never forget it once you smell it. Now, DKA means there's not enough insulin. It's not taking care of the sugar. So you have hyperglycemia. In DKA, in diabetes, you don't usually have ketonuria. You just have hyperglycemia. But with DKA, well, the K is ketones, right? And you have ketones in the urine, okay? DKA is caused by what? Well, look at the symptoms. What do you have? Well, you have hyperglycemia and ketonuria. Those are the two big symptoms you see. So what you have is a lack of insulin, and the body is using other types of fuel. Now, let me explain, now that we've had both of these questions, a little more about diabetic ketoacidosis. So your body doesn't have insulin, so it can't eat sugar. So you have blood sugars, 500, I've seen them over 1,000, okay, in DKA. But your body says, I'm really hungry. What can I eat? It goes, proteins are the next thing I'm going to eat. So it goes and eats protein, and what happens? Byproduct is your ketones. Okay, so when you don't have sugar, the body is pretty neat and will go looking for something else. And the first thing they look for is proteins. Therefore, that's why you have ketones being spilled. A diabetic child complains of feeling jittery, blood sugar is 45. What's the best treatment? Now, when you read these questions regarding all different, lab values are showing you, always make sure you look at patient condition. This child is complaining of feeling jittery. That means they're awake. They're good enough to swallow food. You don't have to give IV D5W or IV Dextran, nothing. You can give this child something to eat. A cup of orange juice. And then after that, you would give maybe, a turkey sandwich, because the protein with the carbs is a better choice, longer lasting than orange juice. You give insulin to this child, you're going to have a dead child. So no insulin with a low blood sugar. Your patients experienced a head injury. What would most concern you? Remember, head injury, swelling in the brain. What are some signs of things that aren't good? I mean, we saw the eye already, but we're not talking about the pupil here. And it's something to do with swelling in the brain, pituitary gland, and squeezing it, and now the urine output's gone down. So what are we going to give? Mannitol. So we get that going, and that swelling is in that brain for sure. A multi-select. What would alert you that a child's head injury is deteriorating? Well, all children with a head injury are going to have a headache and they're going to be complaining of nausea. That's normal. If it got worse, if the nausea turned into profuse vomiting, and if the headache became severe and constant, that's one thing, but not just the headache, not just nausea. Difficult to arouse and now becoming restless are both. That amnesia is also a change in consciousness would be another thing. A child's been diagnosed with bacterial meningitis. What is the nursing priority of care? What do you want to make sure that you're doing for this child? Bacterial meningitis. I mean, a lot of these things here are good. Priority. And it's antibiotics for sure. Yes, and take an output because it's a swelling of the brain due to infection. Elevate the head, yes, can help with the pain. Pain medicine, of course, they have headaches. Good job. What is the primary cause of injury associated with submersion or drowning? You know, I live in South Florida and I've seen many drownings in my career. I think the worst one was one of my favorite physician's son drowned and had a severe insult with a drowning. So when you go underwater, your lungs get full of water. So what is it? It's hypoxia. Okay, it's not the pneumonia, it's that hypoxic insult, which can cause all the problems with respiratory distress syndromes. Two more. Multi-select. Which CSF lab value correlates with bacterial meningitis diagnosis? So you do a spinal tap and you look at it. Number one, you should see clear if there's nothing. Number one, that's cloudy, definitely bacterial. Now there's two things that we see that is elevated or decreased or in a thing. So we will see number one, an elevated white count because this is bacterial. That white stuff is all those white cells. We're going to see that bacteria love sugar. So blood sugar is going to be low because it eats it up. It's good stuff. And then the protein will be elevated. So it could be increased white blood cells, not decreased. Last question. Hyperfunction of the pituitary gland in the pre-adolescence results in what? Hyperfunction of the pituitary gland. And instead of hypodwarfism, this is gigantism. Yes, very good. All right, we made it. Number 3, Alexis, good job. Number 2, Lauren. Number 1, Jess, good job, Jess. Number 4, Kanisha and Mike, good job, guys. What I'd like you to do is sign your attendance attestations. Please make sure you get those done. If you want your grades, put the message in. I have to leave the house shortly. So if I don't do them right now, I'll come back and do them. But overall, you guys have done well. And I think with 1 or 2 questions back, all of you are going to pass in the end. So I like that. Any questions?